Welcome to another lecture of Psychology 101. This is your instructor, Dr. Shadi Bashai, and in today's lecture, we will discuss the third and final part of our unit on psychological and biological treatments, which corresponds to chapter 16 of your textbook. So here we go. In the last lecture, we talked about cognitive behavioral therapy and mindfulness-based interventions and meditation. We start our discussion today with a focus on one of the most successful treatments for anxiety conditions, and that's exposure therapy. Work on exposure therapy began with the pioneering work and the development of systematic desensitization, which was developed by a researcher by the name of Joseph Wolpe. However, systematic desensitization taught patients to face their feared objects or situations while at the same time learning to practice relaxation during the exposure exercises. Systematic desensitization back in the day, so the Joseph Wolpe edition of exposure, worked through the principle of reciprocal inhibition, which is a physiological principle which tells us that for one muscle to contract, the opposing muscle on the other side of the joint needs to relax. And so the relaxation part, the part where patients are learning to relax as they're going through the exposure exercise, is thought of as that reciprocal inhibition principle in action, if you will. Current forms of exposure, however, do not teach patients to relax when they are facing the feared object or event. Instead, patients learn to sit with the anxiety, and over time, the anxiety just naturally subsides. Exposure therapy goes beyond just challenging thoughts and cognitions through reason and logic, and instead teaches the patient to challenge their beliefs through action, if you will. And what we understand about anxiety is that people who are more prone to anxiety or who are suffering from an anxiety condition oftentimes tend to underestimate their ability to cope with certain situations and overestimate the threat of a particular feared object or feared situation. So what people who are more prone to anxiety, some of their cognitions may be that if they face the feared object, something terrible might happen. Okay? And then not only will this relatively low likelihood event going to happen, people with anxiety who are more prone to anxiety, more vulnerable to anxiety, oftentimes also think that not only is this thing that I'm afraid of will happen, but also when it does happen, it'll be catastrophic. It'll be something that will impact my life in a very significant way, if you will. And then finally, alongside this overestimation of threat, people also who are more prone to anxiety tend to underestimate their ability to cope with when this particular feared event does happen, for example. Okay, so doing exposure therapy helps people challenge these particular three beliefs, because they actually face the feared object and they find out that, the thing that I was really afraid might happen didn't actually happen. And sometimes the feared thing does happen, right? So one of my clients, for example, was being exposed to a spider, because that is exactly what they had a phobia of. And in the midst of exposure therapy, and unexpectedly, the spider basically jumped on them. And that was extremely unexpected. And if you had asked the patient before this had happened, this particular feared event or likelihood that the spider might jump or behave erratically during the exposure treatment would have been imagined as a total catastrophe for that patient. However, that does or did happen, and it wasn't a catastrophe at all, and the patient was able to cope even with the most feared of situations, if you will. Okay, so exposure therapy goes beyond reasoning, it goes beyond working on specific thoughts or cognitions, and helps people face their fears, and actions are really quite powerful. So here's how we do exposure in the context of clinical psychology, or this is how mental health professionals typically do exposure therapy. First thing they want to do is create a fear hierarchy, and how that's done is basically the first step is to think of a situation that brings a lot of fear to your heart and to your mind. This could be the goal that you want to achieve. For example, some people might have a particularly strong fear out of giving a class presentation, for example. So that could be the thing to work up towards. That is the highest part of that hierarchy of fear, if you will. And then you start thinking of or generating tasks that are a little bit easier to do than that goal of yours. So if the goal is to give a presentation to a group of your peers, and you rate that as extremely anxiety provoking, so 100 out of 100 in terms of anxiety provoking, and your desire to avoid this particularly fearful event is also 100 out of 100, it likely means you need to generate a few other tasks that helps you work up to that major, very difficult to do task. So you come up with as many of these incremental tasks as you possibly can think of. So for this particular goal of giving a presentation to a group of peers, you might think of maybe the first task is perhaps to work on a script of that particular presentation. Maybe rate the fear out of 100 then. And the next step maybe is to get that script of your presentation and do it in front of your partner, your significant other. Okay? Maybe rate that out of 100. Maybe the patient will rate that 50 out of 100 in terms of how anxiety provoking imagining doing that particular task is. And then you work your way up. Maybe give the presentation to 2 of your peers instead of the full class. And then finally, at the very last step is to give the presentation to your peers exactly as is consistent with your goal. And the idea here is you want to start with one of these tasks leading up to your major goal, and you want to start relatively easy. You want to start somewhere near the bottom of that ladder in terms of ease of completing that task, in terms of how much fear it generates. Because it's obviously easier to start at something easier and makes you more likely to stick with it. But not only that, getting over these less fearful initial few tasks gives you a lot of confidence and a lot of mastery to keep going and working on the rest of the tasks so that you can achieve that final goal of giving the presentation or having a spider walk over your hand, for example, or having a snake slither all over you, or being very close to a snake. These are all examples of phobias that people often work on in the context of exposure therapy. So how well does exposure therapy for anxiety work? Extremely well. And I have CBT in this slide here because oftentimes CBT for anxiety involves the inclusion of an exposure types of exercises. Okay, and we find that CBT that has an exposure component associated with it, and usually CBT for anxiety has that behavioral component with exposure, but also has another component that works directly to challenge negative cognitions in the context of anxiety. And if you get that package deal of CBT with exposure and work on cognitions, effect sizes are relatively large. Okay, so it means the treatment works for a big segment of the population and has a pretty large effect in terms of what it can do to help patients get over their anxiety. Okay. So it looks like the strongest effects are for things like obsessive compulsive disorder through something like exposure and response prevention, and acute stress disorder, which is a disorder that is a preamble to post-traumatic stress disorder, but doesn't last quite as long and appears right after the traumatic event. So acute stress disorder appears a few hours after the traumatic event and lasts only a month. If it lasts beyond a month, then we start to consider things like post-traumatic stress disorder diagnosis. But anyways, the full package of CBT with exposure and work on cognition works quite well to offset anxiety-related symptoms. However, it looks like the most active ingredient there is the exposure. And in fact, if you take the cognitive work out of CBT entirely and only do exposure-related work with someone who is suffering from anxiety or a phobia, you find that exposure works just as well as the full package of CBT, if not even more efficacious. So facing your fears, facing the very thing that brings you a lot of anxiety and angst is very much associated with psychological growth and very much associated with reductions in anxiety. Because remember, you learn to challenge your cognitions in the most powerful way possible, which is through action. So there have been criticisms of exposure therapy, and I want you to remember that there is no treatment that is without criticism, and there is no theory of psychology or psychological functioning, if you will, that is a complete theory that is without some kind of opponent or some kind of criticism. And the case is no different for exposure therapy. Turns out that we can't really expose people to everything that they're afraid of. So obviously we cannot do in vivo exposure, so real life exposure over traumatic events and PTSD. You can't expose people to traumatic events again, because of course that would be extremely unethical to do. So right away there are a few things that you cannot expose people to, and in fact lots of people have death anxieties, for example. You cannot expose people to death, of course, because that will defeat the purpose. So a question here comes to mind, and I want you to consider this particular question. Is exposure, is allowing people or encouraging them to face the very things that they're afraid of, is that ethical? And remember, when patients are going through exposure therapy, it's not easy. It's not easy as you can imagine, right? So think of something that you're quite afraid of, and imagine a therapist encouraging you to do that very thing that you're so afraid of. It's not easy for a lot of patients, and in fact, it brings up a lot of anxiety and a lot of distress at that time. So it begs the question: is exposure ethical? Let's talk briefly about other forms of psychotherapy. So far we've been focused on one-on-one forms and face-to-face forms of psychotherapy. However, there are other formats of psychotherapy, if you will. And one of the most commonly used formats is the group therapy format. And the reason why the group therapy format is popular is because one or two therapists are treating a number of patients at the same time. And the number of patients here ranges from anywhere from 3 to about 20 people. And given the fact that only one or two therapists are involved for as many as 20 patients, group format of psychotherapy can be quite efficient and can be quite time-saving and way less costly to each individual patient, as you can probably imagine. And in fact, some problems lend themselves better to this group format of therapy than other problems. And one of the best way you can use group therapy is probably to treat something like social anxiety disorder. And the reason why I say that is because having a group format to treat a particular condition like social anxiety disorder gives people a platform to even practice some of the social skills and some of the exposure-related exercises right in house, if you will, right with the people that you're going to therapy with. So it can be quite a powerful way, and it can be quite cost and time efficient, as you can probably imagine. Let's talk a little about Alcoholics Anonymous, or AA. It was created in the 1930s by joint effort by a physician and a pastor. And for that reason, and I'll show you what the 12 steps are in about a second, but for that reason, you find that the 12 steps of the AA program are very much imbued and enshrined in spiritual or religious language. Remember, one of the creators at the time was a pastor, and very much saw spiritual matters as extremely important in treating issues like alcoholism or substance abuse at the time. So very, very influenced by religion. And it is really quite a popular form of self-help intervention. And the concept behind it, AA, is that they use peers who have gone through the program as the paraprofessionals themselves that guide the group therapy. However, there's never any involvement from trained or professional therapists, because it's a peer support type of a program or type of intervention. Very little research, unfortunately, of the effectiveness of AA and the effectiveness of the 12 steps, and very much adopts a disease model of substance use, meaning that Alcoholics Anonymous believe that substance use it's a disease that can be cured, if you will, and has or is associated with some kind of a psychological or a biological pathology that, like I was saying earlier, can be identified and can be cured over time. So it's very much borrows from the medical model and really conceptualizes of these issues as a disease. Here are the 12 steps of the 12-step program. Okay, and I want you, if you have the time, just to take a minute to read a few of these steps and perhaps notice how religiously influenced these 12 steps are. Current editions of the AA or the 12-step programs, they're not as blatantly spiritual or religious as it is in the original 12 steps, as you can see in front of you right now. And in fact, many of the current 12-step programs replace the word God with other things like higher power, etc. Okay, but you'll probably recognize many of these different steps because they made their way and they're quite ubiquitous even in pop culture. Here's another format for psychotherapy that we didn't talk much about. I may have alluded to this particular format in other lectures, but we didn't have time to discuss it in any detail. Family therapies. And family therapies have the idea or the conceptualization of disorder as it's never really one patient's issue. And for that reason, you can't really just diagnose a patient with one particular disorder or a problem. Any kind of problem that even one individual is exhibiting is a symptom, if you will, of a problem within the system. And that system, from a family therapist perspective, is the dysfunctional family system. And for that reason, the patient is almost always the entire family and not the individual. So the focus is on how members of the family interact with each other and how these interactions, these problematic patterns create the symptoms that you see as manifested in one patient or more than one patient, if you will. Okay, so family therapies deal with the entire family system, and the patient, for that matter, is never an individual, but almost always the entire family. Operant procedures have been around since behaviorism first began in the 1920s and 1930s, and the concept here is you provide people with some kind of reinforcement for doing positive behaviors, therapeutic behaviors, if you will. Okay, and one of the most powerful uses of operant procedures and behavioral techniques has been in the use of applied behavioral analysis to treat a condition like autism spectrum disorder. Autism spectrum disorders are a group of quite pervasive developmental conditions that affect communication and behavior in a very, very significant way. And although people of any age can be diagnosed with autism spectrum disorder, people have to be showing symptoms really early on in life, as early as the first couple of years of life. Okay, and operant procedures have been used in this way through applied behavioral analysis to help kids with autism spectrum disorder. And if you have a moment, I'm going to challenge you to stop the video right now and click on the embedded YouTube clip here in your lecture slides. And this embedded YouTube clip will show you a discrete trial training that is done as part of applied behavioral analysis to help children with autism spectrum. And it really shows you the power of using operant procedures and behavioral therapy in helping kids even with this quite a severe condition. And the concept behind applied behavioral analysis is break down all the teachable social and communication skills that children with autism spectrum disorder often really struggle with. Break those down into discrete behaviors, and after intense training, you can actually isolate each of these communication and social skills and work with the child to reinforce these behaviors through a systematic program like applied behavioral analysis. Okay. Finally, there's token economies and aversion therapy. Token economies is basically a credit system, again, based on the principles of operant procedures and operant behavior, operant conditioning. So token economies build credits for appropriate behaviors that the clients or the patients are displaying. And then at a later time, people can cash in that credit for items or for things that they particularly enjoy. Okay, so that's token economies. And finally, there's aversion therapy. And an example of aversion therapy is something like antabuse, and in the context of alcohol use disorder. And antabuse basically is this pharmacological intervention that when people take it, and if they're taking it regularly, anytime they consume alcohol, they get violently ill. And it was supposed to be a punishment, if you will. That's why it's called aversion therapy. It's supposed to be a punishment for every time somebody with alcohol use disorder engages or relapses in their use behavior. Unfortunately, however, the treatment only works if you're taking the antabuse regularly. Otherwise, it really doesn't work. So there's mixed support for the use or the effectiveness of aversion forms of therapy. Let's talk a little about biomedical treatments. And the reason why I like to spend a little bit of time on biomedical or pharmacological treatments is because they are extremely commonly used nowadays. And in fact, since the advent of the very first pharmacological intervention, thorazine, which was discovered accidentally as an antipsychotic medication actually for patients who are showing signs of schizophrenia. Ever since that time in the 50s, if you fast forward to today, close to 15% of the population of North Americans 12 years or older are on some kind of pharmacological intervention, especially antidepressants, which are really quite common. So psychopharmacotherapy is the use of medication to alter brain chemistry or physiology to treat psychological symptoms or psychological conditions. And there have been several of these interventions that have been adopted and used to treat several different conditions in our DSM. Today, there are pretty much medications for most psychological disorders, including anti-anxiety medication or anxiolytics, as we'd like to call them, antidepressants, mood stabilizers in the context of bipolar disorder, for example, antipsychotic medication, which is often called neuroleptics, and psychostimulants, which are pharmacotherapy procedures used or treatments used for conditions such as attention deficit hyperactivity disorder or ADHD. Even though many of these pharmacotherapy interventions work, so they're efficacious according to a lot of research, we don't exactly understand why or how they work. Let's talk about antidepressants for a second. And we talked about antidepressants several times at this stage. But one that I'm going to focus on are the selective serotonin reuptake inhibitors, or SSRIs, because that is really the current forms of antidepressants that most people are using today to combat or to work on depressive symptoms. So the idea behind it, and I'll show you a little mechanistic graph in a second, the idea behind it is they block the body's natural sweeping away of leftover serotonin between the two neurons. So naturally speaking, one neuron will release serotonin and it will be left over in this little gap. And the longer it's left over in the gap, the higher the likelihood that the serotonin molecules will be picked up by the adjacent neuron. But the body has a natural sweeping away function, if you will. If the neurotransmitter of serotonin stays too long in this little gap between the neurons, the body naturally just kind of sweeps it away after a little while. So what SSRIs do is they stop this sweeping away motion and they leave the molecules of the neurotransmitter in the synaptic gap or synaptic cleft a little bit longer, hence increasing the likelihood for it to be picked up by the adjacent neuron. Okay, so they block or lock the reuptake or the sweeping away of serotonin. Some of these examples include Prozac, which is the market name for fluoxetine, which is the actual medicinal name. And SSRIs, typically speaking, have a few untoward side effects. About 40% of people taking SSRIs will report some significant side effects, including gastrointestinal issues, sexual dysfunction sometimes. Weight gain is often a problematic thing. And amongst adolescents, it increases, unfortunately, suicidal ideations and gestures, even though it doesn't increase it dramatically, increases it from about 2% to 4%. Another form of psychopharmacological intervention are anxiolytics, and we talked about benzodiazepines a little bit in our previous lecture. And benzodiazepines are, market names include Ativan, Xanax. They're all GABA agonists. And if you remember my discussion about GABA, GABA is this neurotransmitter that inhibits the activity of the central nervous system. So what benzodiazepines do is they increase GABA. They're GABA agonists, increase this inhibitory neurotransmitter GABA in the brain, which inhibits the emotional parts of the brain along with everything else in the brain, of course. So it inhibits central nervous system activity, generally speaking, and therefore makes people less anxious. Overall, people who are on long-term medications are not advised to use benzodiazepines for anxiety. For more long-term solutions, patients are often placed on SSRIs, even for their anxiety conditions. Okay? Lithium, we talked about briefly, is a mood stabilizer for the cycling between depressive and manic episodes, sometimes used even for psychosis or for the positive symptoms of schizophrenia. We really don't understand how they work, and one part of the problem with lithium is that if someone takes too much of lithium, they can experience something called lithium poisoning. Okay, so the doses have to be monitored fairly carefully, and the side effects have to be monitored fairly carefully if somebody is on this mood stabilizer. So remember, there was Thorazine, and Thorazine was the very first form of neuroleptic that was used to battle psychotic symptoms. And it worked mostly on diminishing or reducing dopaminergic activity in the brain, which really was believed at the time to be one of the major culprits, especially for the positive symptoms of schizophrenia. So first-class antipsychotic or neuroleptic medication really operated through the reduction of dopamine in the brain. Problem is, dopamine is required for healthy motor function. And therefore, when the first generation of antipsychotic treatments worked directly to reduce the volume of dopamine in the brain, people often suffered a condition called tardive dyskinesia, who were on the first generation of antipsychotic medication for a very long time. And tardive dyskinesia pretty much looks like Parkinson's, unfortunately, which are these severe problems in motor function. And fortunately, there was a second generation of antipsychotics that was developed. We call those atypical antipsychotics. And the idea behind them is that they don't just work on the dopaminergic system. They also work on the serotonin system. And it basically balances the ratio between these two neurotransmitters, dopamine and serotonin. And for that reason, the second class of neuroleptics really helped reduce the number of patients who were being diagnosed with tardive dyskinesia. Okay, so that was a very important development as well that prevented a lot of these untoward, really negative side effects of taking pharmacological interventions. The last psychopharmacological intervention or biological intervention that I'll talk to you about is electroconvulsive therapy, or ECT, used to be called shock treatment or shock therapy. And shock therapy or ECT basically involves applying a brief electrical circuit or current directly to the brain. And this application of this electrical current to the brain often causes temporary seizures. And typically speaking, when someone is being prescribed ECT, it is for cases of extremely severe and extremely treatment-resistant depression. And people who undergo these treatments oftentimes cycle between all kinds of different antidepressant medications and oftentimes try one or two or sometimes three psychotherapies to no avail, unfortunately. So ECT is often used as a very last resort for people who have severe forms of depression. And the reason for that is, obviously it's quite, imagine it, right? It's this inhumane, really, really painful thing to go through. Not only that, there have been some side effects that have been reported as a function of doing ECT, including problems with short-term memory. Lots of patients report short-term memory loss. And really, really uncertain as to why or how ECT actually works. Some people believe that this electrical current that is applied to the brain helps patients reset the brain somehow. But we really don't understand the mechanism. We really don't understand how it works. Typically speaking, patients with severe depression get about 6 to 10 different sessions or 6 to 10 different treatments before seeing any remediation of symptoms. Here's what a depiction of current day ECT treatment looks like. So it's a bit more controlled and a bit more humane than I'm sure images you had in mind, which were the original application of ECT. Nowadays, it's a very, very medicalized and highly controlled procedure, as you can probably see. Here's the puzzling part. ECT is one of the most effective, and in fact, just based on this number here, it is the most effective treatment for depressive symptoms. 80% of individuals who undergo a course of ECT treatment or electroconvulsive therapy would actually benefit from the treatment and report significant improvements. However, and given the side effects and given just the inhumane nature of it all, okay, it still remains as one of these very controversial treatments and oftentimes just prescribed for people who have tried pretty much anything or everything, and they're just hoping for any kind of relief. Unfortunately, and much like other interventions in depression, given the recurrent or chronic nature of depression, as soon as you stop the medication, about 50% of people experience relapse in 6 months. And as I mentioned earlier, lots of people report short-term memory issues, including confusion, cloudiness, etc. And we really, really don't understand how the treatment works at all. So that brings us to the very end of our course. And at the very end of our course, I want you to step back a little bit from all of this material that we discussed. And I want you to think about where you see psychology heading in our future. Do you see psychology occupying an important space in politics, in technology? Do you see technology as continually being adopted into psychological interventions? If you remember, one of the very first slides that I showed you was a question about what is psychology to you? And now that the course is done and we discussed all the material there is to discuss, I want you to reflect about what you've learned throughout this semester and how you've changed perhaps your conceptualization of what psychology is. What do you know now about psychology that you didn't before? And perhaps what surprises you about the field? So take a minute to really consolidate your learning. That's it for me. It's been fun. I wish you all the best of luck in the final exam and in your future academic endeavors. Till next time.